Hello and welcome. Thank you for being here today. My name's Jonathan Tan, and I'm a pediatric anesthesiologist who's had the privilege of caring for children and families at four of the leading children's hospitals across the United States. I'm the Division Chief of General Anesthesiology at the Children's Hospital of Philadelphia, and today I'm honored to talk with you about how we care for our youngest and most fragile patients by optimizing and personalizing neonatal and infant ventilation in the operating room. Let's begin. Neonates and infants remain the most vulnerable population undergoing anesthesia. They have the highest risks of intraoperative complications and cardiac arrest. Their physiology is rapidly evolving, their organ systems are immature, and they represent a wide variation in congenital conditions. They are more sensitive to anesthetic agents, and they have extraordinarily narrow safety margins. These factors combine to create a level of risk that is unmatched in any other age group that we care for. Even small deviations in perioperative care can have significant consequences. Neonatal and young infant anesthesiology requires deep expertise, reliable systems, effective and experienced teams, and technology capable of delivering accuracy and precision at the smallest scales. Ventilating neonates and infants is fundamentally different from ventilation in older children or adults. Neonates and infants have higher oxygen consumption, immature alveoli and surfactant systems, and a natural predisposition to atelectasis and ventilation perfusion mismatch. Their reserves are extremely limited, and desaturation, as we all probably know, occurs rapidly. Preterm infants represent an even greater risk group, with smaller lung volumes, reduced FRC or functional residual capacity, and minimal tolerance for error. This is why optimizing and delivering precise ventilation is central to their care. The optimum approach to ventilating neonates in the operating room focuses on a lung protective strategy. In the operating room and under general anesthesia, our goal is clear. Our ventilation strategy must deliver effective oxygenation while minimizing the risk of lung injury. We rely on individualized, lung protective approaches that require consistency, precision, and the ability to adjust in real time. Our practice today is a result of decades of research, clinical practice, and advancement of monitoring and ventilation technology. In addition, many of our foundational principles of optimizing ventilation for neonates and infants come in partnership from our critical care medicine colleagues. We've learned a tremendous amount from our pediatric critical care colleagues. Pediatric critical care medicine research frameworks have taught us that low tidal volumes reduce lung injury, that driving pressure matters, and consistent lung protective ventilation saves lives. And recruitment must be individualized. These principles strongly influence how we ventilate neonates and infants in the operating room today. But as we all know, the ICU and the OR are not the same. ICU ventilation lasts days to weeks, often for ARDS or chronic lung disease or other pulmonary complications. In the operating room, we ventilate for minutes to hours, usually in patients with fragile, but perhaps more normal lungs. The operating room brings unique challenges though. Anesthesia-induced atelectasis, surgical positioning, pneumoperitoneum, intrathoracic procedures, shared airway management, and rapid transitions during induction, emergence, and handoff. Even though many of our guiding principles come from an established knowledge base from critical care, neonatal and infant ventilation in the operating room remains fundamentally different from ventilation in the ICU. Ultimately, the context matters. ICU principles guide us, but neonatal and infant ventilation in the operating room requires its own personalized, procedure-specific approach that can adapt in real time to changes that can happen moment to moment. When caring for neonates and young infants, a cornerstone of safe ventilation begins with the right technology. We rely on modern anesthesia ventilators that provide compliance compensation, fresh gas flow compensation, and high accuracy volume delivery specifically designed and tailored for very small patients. Several key concepts anchor safe ventilation in neonates and infants undergoing anesthesia care. We should use lung protective tidal volumes of approximately 4 to 6 milliliters per kilogram. We should maintain adequate but not excessive PEEP, typically in the ranges of 3 to 6 centimeters of water. We should minimize FiO2 to avoid hyperoxia and oxygen-related injury. And of course, we should avoid hypocapnia. These strategies reduce the risk of volutrauma, barotrauma, atelectasis, and oxygen toxicity. We can apply lung protective ventilation bundles, which include low tidal volumes, moderate levels of PEEP, short inspiratory times, permissive hypercapnia when appropriate, and frequent reassessment of mechanics and gas exchange throughout the entire anesthetic. Each case and each patient must be tailored to each child's physiology and reassessed throughout the continuum of the procedure. Modern anesthetic care for neonates depends on precision. Early generations of anesthesia ventilators struggled to deliver accurate volumes in the neonatal range because of several factors, including circuit compliance, fresh gas flow variability, and uncuffed endotracheal tube leaks. Today's advanced ventilators can provide compliance compensation, fresh gas flow compensation, and highly accurate microvolume delivery. These advancements allow us to ventilate patients weighing as little as 1 or 2 kilograms with far greater accuracy and consistency through a dynamic surgical process. This represents a significant leap in our ability to provide safe and personalized care. Achieving precision is not just about technology. It requires a coordinated system of practice across the continuum of the perioperative arena. Adopting advanced airway technology, video laryngoscopes, and other induction tools to maximize safety and reduce time between induction and securing the airway is important. Minimizing apparatus dead space to prevent CO2 retention in the smallest patients is critical. Selecting appropriately sized cuffed microendotracheal tubes to reduce leaks and ensure accurate volume delivery is essential. So is ensuring proper humidification, which is essential for airway protection and gas exchange. We should use continuous monitoring, including capnography, pulse oximetry, and real-time ventilator data and waveforms. And through the use of analytics and feedback loops, we should adjust ventilation dynamically across compliance, gas exchange, and physiologic changes. Together, these practices transform ventilation from not just a mechanical setting into a personalized strategy perioperatively tailored for each individual child. Delivering truly personalized ventilation for neonates and young infants goes far beyond choosing a ventilator mode or setting a tidal volume. It requires a coordinated system, an ecosystem of technology, people, and practices working together. Delivering precision ventilation also requires a broader system, elements working in harmony. We need effective communication across the perioperative team. We should adopt modern ventilator technologies in all of our sites that are capable of advancing accurate delivery of microvolumes. We should adopt AI and clinical support tools to guide safe ventilation strategies. We should use ongoing education and training moments to maintain our expertise and the future of our specialty. We should integrate clinical practice systems, ensuring consistency and reliability. And we should ensure that we have high-quality handoffs going to and from the operating room from the NICU or the PICU. We should continue to advance research to refine our best practices, and we need strong industry partnerships to advance the technology needed to care for our smallest patients. Together, these components transform ventilation from a set of machine settings into personalized, precise, and protective strategies for neonates and infants. Optimal ventilation in neonates and infants is fundamental to advancing perioperative patient safety. Safe ventilation protects vulnerable lungs during the most physiologically unstable periods of care. It also reduces perioperative complications and advances safety. It strengthens the continuum of safety from induction through emergence and into the postoperative recovery period. This is not just a technical aspect of anesthesia, it is a core patient safety priority. As we look forward, one message stands out clearly. Systems, teams, and technology form the foundation of safe neonatal infant ventilation. When we combine evidence-based practice, modern ventilator precision, coordinated teamwork, and ongoing innovation, we elevate the standard of care for our smallest patients. This is how we protect them. This is how we advance safety. Thank you for joining me today.